it ranged from 1 in 50 at age of 50, and might increase up to 85, 1 in 9. So this is, they call it in US, silver tsunami. By the year 2030, 1 every 5 American will be more than 65 years. More than 80 years is the fastest growing segment of US population. Incidence and mortality from cancer increases with age. 60% of all cancer diagnosed and might be reaching 70% of mortality occurs in persons aged 65 years or older. I will not define the elderly, so I will not, the ladies will not be angry to me. But this is the cutoff, they call it in the literature as 65. So the older the patient are special because they are the majority of the patient we are going to treat in the future. You know, cancer is the disease of aging. Carcinogenesis is time consuming. We have the incidence of many types of cancer increases with age. The older the patient, the greater the potential for DNA damage, and the greater cumulative damage to DNA will be greater potential for malignancy. However, damage will involve certain specific genes, which will include the activation of oncogenes and deactivation of tumor suppressor gene, which at the end will lead to carcinogenesis. You know, elderly have a lot of problems. Age itself, geriatric syndromes, they are malnourished, incontinent, they have hearing problem, they have polypharmacy with multiple medication, they are depressed, fragile, the age-related decrease in functioning, either physical or cognitive, they are disabled, and they have comorbidities, and it has been found that more than 80%, in 80% of patients more than 65, they will have one or more chronic disease. And if we compare young to older, young usually they have single serious condition which will dominate the clinical picture, and they tolerate the acute severe side effects very well. And the main goal of treatment is improving survival or cure even. On the other hand, older patients, they have they have multiple illnesses with morbid conditions, variable tolerability to specific treatments, and the main goal in this patient either survival or improving quality of life. So if we have 75 years old patient who is healthy, she might live 12 years. If they are average risk, 11 years maybe, and if they are sick, it might be decreased to 7 years. So the older the patient, living longer, living healthier, more indication for anti-cancer therapy, and many more patients in need for getting more therapy. As we said, breast cancer in elderly. However, it has been noticed they have poor outcome, and this is due to several reasons, might be delay in diagnosis and undertreated. And this is the main topic of the lecture. We have some facts from reviewing literatures and treating breast cancer in elderly. First, breast conserving therapy and axillary node dissection are less in comparison with others. Radiation therapy likely to be omitted, as Prof. Yasser Bahadur said, in special situation, and less frequently receive systemic therapy. However, in contrast, hormonal therapy is more in these populations. And the reason it is multifactorial: poor performance, limited support, and they have difficult migraine transportation, family preference, and many other things. And also the clinical trials, they are not concluding elderly patients. I will show you now, in spite of all this high incidence of breast cancer in elderly, it has been noticed might be less than 90% of elderly population including in the clinical trials. This is the data from US again. If you notice here, I don't know if the... Fine. Okay. Thank you very much.
Welcome.
Okay. Sorry for that. You know, this is US data. The publication in breast cancer more than 20,000. However, in elderly, it is less than 10%. And this is a multiple reason for that, as we mentioned. So in elderly, this is Ardal al-Umr. Everything is changing down. In absorption, in the pharmacokinetics, even the enzymes responsible for metabolism of the drugs will be affecting, and this will affect the metabolic rate of the chemotherapy. Excretion will be decreasing with decline in GFR, and always remember, please don't depend on creatinine. It might be normal, however, the GFR might be decreasing. See how this the graph, with increasing the age, the GFR will be decreasing, and this will affect the decision regarding chemotherapy. So there will be change in pharmacokinetic, and this will affect the pharmacodynamic. In elderly, change in fat deposition will increase the drug resistance. Many things also, change in total body water will increase the elimination of chemotherapy, and many others. So change in pharmacodynamics with multi-drug resistant genes they are developing. All of this will affect also the decision regarding treatment or not. Also the cancer cells, the cancer cell will not be responding very well in elderly, because the elderly have poor circulation, and this will affect again the results. So it is multifactorial. So another important thing also in changing in pharmacodynamic will increase the susceptibility for myelosuppression, mucositis, cardiac toxicity, and central nervous system toxicity. So this is the most important question. What is the goal of cancer treatment in elderly? Are we going to cure, prolong survival, prolonged active life expectancy, or effective only symptoms management? And the most important always, we should not do harm to the patient. If we are not going to benefit, we should not do harm as well. So first ask ourselves, is the patient going to die with cancer or not? Is the patient going to live long enough to suffer the consequences of cancer? Is the patient able to tolerate our treatment and the complications of it, and also the social support and the family support as well? And again, there is one important point. Decision, for some physician, routinely decided upon only what is the age of the patient. It is not true. We should differentiate between chronological age and physiological age, and upon it we should decide. So this is what we know, the echo performance status, but this is not the only one we should depend on it. There is what is called comprehensive geriatric assessment by geriatric, sometimes oncologists. There is sub-field now in oncology. We look at many factors, which is functional status, the comorbidities, the concomitant medications, the cognitive function, psychological. But this is time consuming. It might take 1 hour or even 1 hour and a half. And this is the long list. We cannot go through all of it. So what they did, I think this is reasonable to consider, what is called Charlison Comorbidity Index. 1 point for each, which include the comorbidities the patient is having. And at the end, we'll calculate this Charlison Index score, how much the patient is having. If the patient 0 has no comorbidities, 1 year survival might reach up to 88%. If had 5 or more, it might decrease to 15%. So this is very important to consider it. And now if I talk, Dr. Ayman is here. No role of surgery in elderly, of course. But anyhow, no, just I'm joking. What I'm saying, this is the Society of International Oncology Geriatric Task Force, again from US. It should be treated the same. Elderly will be treated surgically the same, regarding if a lumpectomy, regarding the sentinel lymph node or axillary dissection, and hopefully at one day, inshallah, we'll not have surgery in our breast cancer board. But anyhow, the expectation from surgery in elderly, it might be difficult, and this SIOG, the Society of International Oncology Geriatric, they are recommending sentinel lymph node biopsy for elderly patients with a tumor less than 2 to 3 centimeters and no clinical evidence of axillary involvement. I think it will not be much more than others with comparable age. And this is the, how much comorbidity from the surgical point of view regarding the comorbidities and the age. And again, it is like Charlison Index. There is a score for that. I'm not going through for it. Now, what about chemotherapy, which is the most difficult in this situation? Adverse factors, which include polypharmacy and more than 3 active comorbidities. Elderly patients have decreased bone marrow, reserve. And the last NCCN guidelines actually consider the age of 65 or more to give primary prophylaxis, GCSF, and don't wait for febrile neutropenia if you decide to give chemotherapy. Previously, they are saying if the chemotherapy will affect maybe 20% or more suspicion to have febrile neutropenia to give. Now they are considering the guidelines in NCCN, last one, to consider the age itself might be as a risk factor to give primary prophylaxis. And there is a lot, again, of physiological change will affect chemotherapy. We will have slower repair of DNA. This will be prolonged toxicity. They have anemia, they have many other things which will affect the chemotherapy. So the SIOG guidelines recommend adjuvant 4 courses of anthracycline containing over CMF. So if you will give either AC times 4, better than CMF alone. And among patients with increased cardiac toxicity, you might be away from anthracycline. You can give docetaxel with cyclophosphamide instead of ibuprofen or adriamycin. And be aware always, they have polypharmacy, many drug interactions, like, for example, cyclophosphamide, elimination, decrease in patients with impaired renal function. 5, if you fluorouracil-induced cardiac toxicity might be Brin's metal angina as well, and coronary spasm. Taxines will have hepatic impairment, increase the toxicity. And the same thing for many other medication. I will not go through all of them. What about post-operative radiotherapy? Again, it is the same indication, but we can omit, as we said, as Prof. Bahadur said, in selective patients, those who are more than 70 years, have small tumors, less than 2 centimeters, AR positive, clinically node negative, you can omit radiation as adjuvant setting. What about hormonal? Hormonal therapy, they have clear benefit. In women with hormone receptor positive early breast cancer, AIs will be the drug of choice. I will not go through all of this, but remember, if you give AIs, aromatase inhibitors, either anastrozole or letrozole, the osteoporosis will increase, and it is advisable to start one of the biphosphonates on like 6 monthly basis. It has been found that at 1 year, the bone marrow density at the lumbosacral spine will be 4.4% higher upfront treatment, and don't wait. And in addition to, don't wait for osteoporosis to happen, because they are elderly, they are at high risk, and so please give biphosphonates on 6 monthly basis in addition to calcium and vitamin D. This is the last, metastatic breast cancer. If you decide to give single agent, HER2 will be the same, but please check echo before that. And I think this is the most important. I will not touch the computer, but so please, if you have, I need the pointer here. I don't know. Okay. Okay. Just in evaluation, this is the most important slide for all of you. This is the flow sheet, how to assess. Say you have now a new case of breast cancer. You assess the frailty and fragile the patient, if she is disabled or not, how many comorbidities she is having, and the geriatric syndrome. If it is positive, I think it is advisable to refer to palliative care. Now, if it is, she has not much of this, assess the life expectancy and the age and the comorbidities. If the life expectancy will be more than cancer survival, okay, what you will do, first we'll choose this one. If life expectancy, again, less than cancer survival, assess, is the cancer influence quality of life? If yes, refer to palliative. If not, no influence of cancer on quality of life, you can give the patient follow-up. Now, If the life expectancy is more than the cancer survival, assess if there is any contraindications for anti-cancer treatment. Risk and benefit of the anti-cancer treatment on activity of daily living, nutritional status, social support. If the risk is less than benefit, you will give anti-cancer therapy. If not, the risk more than benefit, you will refer the patient to palliative. This is the summary of what I talk about. So in conclusion, the main determinants of outcome and survival are tumor characteristics and comorbidities, not the egg itself. This is very important. And an otherwise healthy older woman can and should be treated with the same standard adjuvant chemotherapy as younger woman. Treatment should be individualized. There is strong evidence that older women tend not to have their best cancer management in accordance with evidence-based national clinical guidelines. There is growing body of evidence around the usefulness of integrating the principle and practice of elderly care into oncology, and always we are saying multidisciplinary team to decide the appropriate management, as Dr. Al-Khair said, is the best approach. This is my last prize. نسأل الله ألا يردنا إلى أرض العمر. Thank you for attendance. السلام عليكم ورحمة الله.
And both negative, we proceed with second generation and then with the protocol. But not yet. We did not do it for any patients yet. It's step by step.
Did you discuss oophorectomy?
This patient, yes, already she had oophorectomy. I forgot to mention. I forgot to mention.
Dr. Al-Khair, what do you do for patients, dilated patients who are not, they don't have eligibility for national card, like her sister?
Usually we have a program and have the high-risk cancer prevention clinic. So the relative of the carrier patient, we make them eligible and we screen them only for this test. And whatever consequence for it, genetic counseling, and we start with genetic counseling first, and then we screen them. If they are carrier, we offer them the option. So we make them eligible.
Thank you very much. Now we invite actually for a panel discussion, there is no time. Invite Dr. Madina, Dr. Abdul Mohsin, Dr. Ahmad, and Dr. Ahmad to come here for a presentation and discussion.
So I have to present first Dr. Mohammed Naeem Hassan. He is our senior registrar in the medical oncology clinic at Madina. Dr. Naeem, he has his work and his degree in the UK and joined us 1 year, and we are very happy.
We have this lady presenting to us early 2011 in January. At that time of presentation, she was 32 years of age, and initial presentation was with a large right breast mass. Before coming to us in our breast clinic, she had actually presented to another oncology setup when she was 2 months into her pregnancy. So at 8 weeks pregnancy, she noticed right breast mass, which was progressive in nature quite quickly. She had a diagnosis made of breast cancer in that facility and was advised termination of pregnancy there.
Alright, so it's a typical history of a young lady. She was first, the patient, she was pregnant, and when there was a breast mass, the patient was seen initially by a male physician, and they were telling her it's related to pregnancy. I think it's the same story like Dr. Al-Khair said. The misdiagnosis is one of the big issues, specifically in young patients. And this patient presented to our breast clinic, mammography, and
yeah. So upon presentation, she was already 2 months post-termination. I think she took some time after termination of pregnancy in recovering from the loss of pregnancy and the psychological effect related with it. she didn't have any significant past medical history and no family history of any cancer.
So the patient presented initially with the mass, and we asked her for 4 biopsy for the patient, and she was not interested to do this, so she was follow-up for about 3-4 months, and she went to another spot where they had 4 biopsy there, and the main point the patient presented that she had termination, and it was elective. The patient agreed about this, and also her husband, she has 4 children, and she has no comorbidities. So it was her decision and her call, and also she was seen by oncologists there. Of course, Dr. Mortel covered the area for the patient with pregnancy, how we can overcome. Actually, it was the first question for us, if this patient or she didn't agree about termination, what we do. But she covered it fantastically, so not tackle this point. So the patient came to us again with larger mass, and she presented with hereditary irregular breast mass fixed with skin involvement, T4, supposed T2, and right axillary neuropathy as well, and the breast was unremarkable. Okay?
It was, after the examination clinic, investigation was ordered, including a mammogram. The mammogram, if we have a look at...
The mass mainly was on the right side, as you can see,
Yeah.
and the left breast is unremarkable. As Dr. Montiel and also Dr. mentioned initially, the density is for the young lady, you can see it very obvious, but on the right side you can see the retraction of the nipple. Okay, so the main point for us, again, this patient, she presented with this picture, and she had the core biopsy initially. Do we need to repeat it again? And the patient, the core biopsy came with invasive duct carcinoma, it was unknown, and she was luminally strongly positive. At that time, we didn't have the ERPR percentage, it was only +3 positivity, and the CRS predefined the calcification present. So, Dr. Abdul Mohsen, as a pathological report, do you think it's significant for us, or what we need is? And how much frequent that you have most of the patient was? So my question regarding this patient, she presented, first of all, I need your comment that you have a pathology report like this. Do you think that the pathology report has enough information, or it's lacking of information?
I think this pathology report has all the needed information. It shows the grades of the tumor, the dental cell types, the ER status, the M2 status, the KS67 is there, and also the cycle component, maybe the grades of the DCIS needs to be mentioned, and probably the percentage of the core biopsy. All the needed information is there, so I think it's fine.
I wish we have lymphopathy patient.
I mean, this is a co-biopsy. I mean, it's a true needle biopsy. We have that information in our final histopath.
We usually comment on LBI on core biopsy.
Okay. Dr. Ahmad, did you think that ERPR, we always need the percentage, not only the strong positivity?
The positivity here for ERPR, we usually comment that it's 1+, 2+, or 3+. And this is defined based on the percentage of the staining, as well as also percentage of the intensity of the ERPR in the nuclei. If it's more than 1% to 25%, we call it, to 10%, we call it 1+. If it's beyond 50%, we call it 3+. It really helps us to define the proper intensity of the staining, as well as also the percentage of the neoplastic cells staining the stain.
How much the P67 important information is for you?
Yes, 7 shows 67%.
No.
It's unknown.
Oh, no?
Unknown.
Yeah, it's
7%.
But could be unknown.
I see. Yes, it's 7. Yeah, this is not profiled.
Yeah. And I will convey this question to Dr. Masaldi. If you have, how much information case accessible considers important for us as a determination of patient strategy? This patient is strongly strongly positive, she's young lady, she's locally advanced disease, P67, how much it will affect our strategy?
I mean, in this case, I don't think it will add much. It will confirm for you what you have seen. I should admit that we are very lucky to have the current vaccine. Consistency in Ki-67.
We put him in purpose.
Yeah. Consistency in the reporting to match the other features is a gift.
Yeah.
And what I do, maybe he does not know this, is we look actually into the nuclear grading within the grade to see whether it matches Ki-67. If I see discrepancy, I might ask him to look again into this.
We actually
That's
look
one
at the nuclear grades. The grade, as you know, it has three components: architectural, and the nuclear, and the mitotic index.
Right.
So in the pathology report, it's strongly recommended to put all these three in the pathology report. So this will allow the oncologists and the surgeons to look at them carefully. Like, for example, if I say grade 2, this is, to me, is insufficient. I have to say grade 2 because of what? Is it architectural 3, nuclear is what, and also the mitotic index. So if the mitotic index, for example, is 1 and the Ki-67 is 70%, I might have out. It doesn't make any sense.
Yes. So let's put a scenario. So if this patient is strongly positive and P67 is about 11%, and in another scenario, P67 is more than 60%, which one you will go, Dr. Mehmet, as a strategy? You will do the same, or you will be in favor of anything?
In those cases, I use it in situations where I have ER positive, node negative, HER2 negative, and I don't have hemodialysis. This is the only clinical scenario where I look at Ki-67. And it depends on the pathologist we have in our institution. So, National Guard in general, they are likely to have Turkish and Proxapine in our institution. So, usually, we can have like a clue from the how the response reacts. So,
I agree with you. We don't have a consistent information, but at least the P67 give you the perfect index. So sometimes when you found something like that, and Dr. Rakushi just mentioned, if you found P67 at about 70 or higher, it means it's activity, which is maybe we can see it maybe with triple negative more than in the luminal data. So back to our scenario, please.
Yes, so I'll just touch upon the CT scan as well before we started any treatment for her. That shows a big right upper quadrant breast mass and that's showing the lymphadenopathy in the right axilla as well. It didn't show any visceral metastases. A bone scan was done as well, which was free of any bone metastases, and baseline blood investigations including full blood counts, biochemistry, CA15-3, but within normal limits, and normal echocardiogram as well. So we've got this young lady here with the final diagnosis of a locally advanced right breast invasive ductal carcinoma, with strongly hormonal positive and HER2 negative, luminal A. She has had termination of pregnancy at 8 weeks of gestation and was 2 months post termination of pregnancy when she presented to us.
So I present this case to you in the tumor board. What do you think is the best strategy for her? Okay.
I don't think, some people might.
That's why we are giving you choices, so give you four choices.
Myself, I don't think someone here has this before me.
Okay, so which one you will go, and why you are favoring?
I go the usual. I don't treat, the biology here again. To me, age is irrelevant. Okay, I really don't put the age in my calculation at all. This is a locally advanced hormonal, seems like luminal type of cancer.
She's luminal A5.
Yes.
Yes. Negative, yeah, positive.
Right. So she needs, the question
But
is.
that's not enough to say that the luminal A just by, ER, PR, and HER2. You need some other.
We are assuming Ki-67 low is that.
If you are, this is.
No, I'm talking assuming this is dominant A.
Yeah, you need as well, you need to know whether her lymph nodes are
But she's
involved.
not
No, she's not
so
bothered.
definitely we
She's not positive. She's
Yeah.
CT is not, she's looking at
CT is, I mean, you need to have, I mean, kind of biopsy to get it, I mean, confirmed before you start any neoadjuvant therapy, so you know what you are doing.
For the sake of discussion, let's say we have proven that she's T3 and 1 and 0. Do you agree with that?
Yes.
Okay. Luminal ATA. These patients, you know, they require neoadjuvant chemotherapy.
Right.
To be followed by, you know, appropriate surgical procedure based on, I think, post-chemo evaluation. And then adjuvant treatment with hormonal therapy and radiation therapy. That's the way of thinking.
You want to biopsy the lymph node?
I would just probe it. I know that this patient is going to have dissection at the end. I know that this patient most likely she will go for mastectomy.
But I don't like this.
Yeah, but you know why sometimes I need to compare them. Sometimes there might some surprises, so it might be different. It might be, to be honest, I faced it one of the clinical situations. It was a carcinoma. It was completely not. So, and even if you look at the guidelines,
I think it's a routine to biopsy.
Yes, I agree with you that taking a biopsy will allow us
and for the choice of the chemotherapy, I will go with 8 cycles.
But I will be very surprised if we get no man in patients with this mass. We know that it's some sort of because of the first station, but it would be a different pathology. It's the percentage less than 20%, but we can consider it.
But the guideline is to do biopsy. So let's
yes.
When I say
but actually, this is not a routine. We usually didn't put from both ways. We have person here, so I'm talking about reality. We just only take from the breast tissue, we didn't take from the lymph node. So please.
Actually, we always do.
No, we always do.
We always
Okay,
do.
so I'll have to do this.
Dr. Madras, why did you say that she would have to visit with mastectomy?
Because one is the location and the other is involving the skin.
It doesn't look like, I mean, it doesn't look like the skin is involved. It is there is thickening in the ultrasound, but there is no direct
I wish
extension.
we had put a
It's
stage
6
against.
centimeters.
3-4 in one lymph node.
If it is retroalveolar central, yes, that is probably very difficult, but if it is not, I mean, at 10 o'clock, I mean, you would expect it, I mean, unless you say that this is retroalveolar, where you probably cannot save her, I would, if it is not in the retroalveolar area, she would have to have a
There's
marker.
no skin involved.
She'd have to have a
Here,
marker.
well, that's the nipple retraction. And
Yeah, nipple retraction does not does not contraindicate, I mean, the conservative surgery if she had a response.
Look at the ultrasound here. You know, I'm very meticulous about these cases, and with hair knows. We have to prove skin involvement by
Yes,
biopsy.
absolutely.
You cannot
If you want
assume
more,
things
it's elementary.
and do mastectomy to 32 years of age because you think skin is involved.
Absolutely.
Prove it to me. It's only a meter, and then I can talk to you. But there's a lot of unnecessary mastectomy done based on suspicion, which is not acceptable.
well, it's a very relevant point. The main one is the lesion was almost occupying the whole breast and it was fixed to the muscle.
Will you say 5 by 3 in
But this is not what you are describing. This is a very localized
5 by
tumor.
3.
Okay,
You know,
this is why the ultrasound.
Ultrasound to me is more accurate than what we think.
Okay.
Okay? That tumor can be shrunken to a conservative surgery.
Yeah, I would have put
But
marker.
it is
You are going to do surgery in special.
Still.
You are going to do conservative surgery in this patient?
As I said, we mark the tumor, we give
Okay.
her the chemo.
Yeah. We usually mark the tumor.
If I have any suspicion of skin, I put a needle. We ask them.
Yeah.
Right? We give the chemo, 8 cycles, I agree with Dr. Metan. And then we re-evaluate. At that point, what surgery needs to be done. Okay, that's one. The other thing, there's one point which maybe we did not touch upon, is the ovarian preservation by using LHRH. To this day,
This
she's
is
only
hormonal
32.
positive. She's not.
So she's not a good candidate.
She's not a good candidate for Holmes study. So she is
No,
not.
we at that time we didn't have the data to confirm or to be consistent. We can start the list from the start point.
Yeah.
So the patient she was receiving at the time will tell you But just please, can we have the mammography again? Because the lesion, you will see in the mammography, this patient can be candidate for conservative even if we have shrunk the tumor totally, and this patient has, we can assume that she had complete resolution.
I cannot really talk about pre-chemo pictures. We have to sit down after chemotherapy.
Yeah, but I'm putting this scenario, if this patient she responded and you have the primary lesion like this, how you do, Dr. Ayman, you will do conservative for this patient, and you know this patient she received chemotherapy, and there is maybe multifocality at the side because the chemotherapy effect on the tumor itself. So usually when I'm conservative, you have to make sure that the safety margin is split. Need your comment, please.
Thank you for giving me the chance to talk. Finally, even the surgical questions being answered by I was just waiting. Can I follow up something?
The mic was
to me, the nipple here is involved. Even with the small tract, to me, the nipple is involved. That's number one.
Yeah, that
number
was
two,
our assumption as well.
Yeah, it's blindly, I will consider this patient, the nipple is involved. Number two, I will put a marker. If there is any chance, I will start with central lumpectomy. The central lumpectomy will take the nipple with us. Okay? And then we can create another nipple. But we have to go to another essential.
And the argument is nipple is involved is based in what?
Yes,
I mean, just the
MRI. Just the MRI. If I look at it,
not an MRI.
And if I have the mammogram, and if I have a radiologist who agree with me, command will add this one. With this mammogram, I will do.
Yeah, we are radiologists.
And I'm not going to see.
Detect the nipple retraction and significant skin thickening. If we compare this big skin is involved, nipple is involved, even the underlying mass can be involved. We should do MRI.
I agree. But I mean, I'm not going to do, I'm not going to do a subcutaneous nipple sparing mastectomy for this case.
Yes.
For sure.
This is not the candidate.
If I will do maybe central lumpectomy with a nipple, okay? Or I will do modified radical mastectomy with LD flap in the same time, or TAM. Or if the patient, sometimes they don't like it because the operation is too long, we'll do it in 2 sittings. But usually, by the way, we do all the oncoplastic surgery in the same sitting. So we do the LD flap or the TAM in the same sitting.
Okay, so allow me to ask a question, also a surgical question. If you have a mass and the patient, she had chemotherapy pre-op and the mass is almost no palpable disease. When you are doing the conservative for the patient, you put in consideration the primary lesion or the lesion at the time.
No, don't forget to put a mark to know where
Yeah,
the
sure.
center of the primary.
Yeah.
The primary lesion is in the mind. You cannot forget about the primary lesion on the side. Even if you see nothing, you will go and do lumpectomy like if the center is still beating, the heart is still beating there where the mark is. Although I'm not seeing any tumor. But we will consider that.
So if you have a 7 centimeter tumor,
Yes.
which became 1,
Yes.
you will remove 8 centimeter?
No, I will review the process of 1 centimeter. I will take it, but I will see where is the marker.
No, the
Now we have a
Marker is in the center.
It has to be involved with me, and this is a big problem. I will be marker plus the 1 centimeter you're talking about. I don't need to go and take the whole thing, okay?
That's what we
Yeah,
have here.
but the marker, the beat, it has to be there. I mean, the marker has to be there, at least to prove that there is no more residual.
So how to make sure there is no residue from the lesion? We know that the chemotherapy by diffusion makes fragmentation of the lesion.
You will never be sure. And I told you before in my lecture, the shrinking of tumor with fibrosis may lead to small eyes itself. But it did not change anything. So you will not.
If I can say as well, the studies did not actually confirm that what removing the remnant of the disease with the irritative lesion did not have any detrimental effect. We should not assume that there is something left behind. These patients will have radiation therapy. Remember, after
Even
there's
if there's something left behind, you have to remember there will be no big change. There is no change between.
The radiotherapy from this?
I just would like to add one thing. The absolute contraindication for considering the breast absolute contraindications for considering breast conservative therapy is T4C and D disease upfront. So whatever stage or T, it's open for debate between the oncologist, perhaps the surgical oncology as well.
That is why skin biopsy is a must.
Yeah.
Because that mistake means mastectomy is sometimes unnecessary.
Exactly.
So biopsy.
Okay, so which chemotherapy you will go?
I go for FIC and then for taxing. Docetaxel usually. I'm not here like Taxol, but
And you determine that you agree with this, or you will have another strategy?
For me, I will go with 4 cycles of AC, and then I will go with 4 cycles of AC.
So you are giving all the chemotherapy before surgery, and then you will put the patient. You are not in the favor of the NCP T16, which is poor surgery followed by another surgery and to assist as well.
No, I will give all the chemotherapy.
You will give all, okay.
Yeah, before the.
Well, it's still an option, and it's a great option. So this patient back to the scenario.
Yeah, so we had 2 good discussion regarding her, and we combined the 2 options together, gave her TAC, docetaxel, apirubicin, and cyclophosphamide, with primary GCSF support.
She tolerated, how about the tolerance?
She was evaluated on each chemotherapy visit. She had good chemotherapy tolerance, grade 1 GI and grade 1 hematologic toxicity as well. After 4 cycles of chemotherapy, she had no clinically palpable disease in the breast or in the axilla. So, complete clinical response. Let's see how is it reflected in any of the images.
I would review the pathology.
Let's
Yeah, it's very unusual. You know, it's only 7% of cases.
Yeah,
But we have also.
But you cannot argue that that doesn't occur.
What I'm saying,
Yeah.
this is very unusual scenario.
My feeling, this patient is probably luminal B, is not luminal A. I mean, based on the character given. And the likelihood is that this is, within the expected range of it. We don't see much of a complete clinical response in those patients, but it is not unusual. It's 7% even in.
They do exist, but when I have 90.
That's why we said that this patient will probably get a marker and possibly.
Had a repeated mammogram?
Yeah, that's the repeat one and the repeat ultrasound.
Actually, this mammogram, I can see no significant difference by mammography, but by ultrasound we can see shrinkage of the tumor, but it's still, unfortunately, it's deeply located. Even now, if we come far away from the skin, still there is skin thickening, and the mass is still abutting the underlying.
This is why we make for the patient another CT so we can just see.
Yeah, I think this
it's
is.
sometimes the mammography, it's sensitive, but in such cases you cannot find it specific. So for the was clinically no palpable disease, and the CT, can you really see the CT, please?
Yeah, I think this is this patient would have needed an MRI. Before initiations of a neoadjuvant therapy, and one after that.
Right.
This is not a CT scan, but rather an MRI. Yeah.
We have 6. You didn't put it, okay, sorry. After I didn't put the CT, but the CT when it's done, the lesion you saw it initially was complete resolution and lymph nodes as well. And this patient, we discussed with her and gave her the options for everything and discussed also the tumor wall. And the patient was elected by the surgery, and also patient agrees about this for mastectomy for her. So we went for mastectomy.
She had 2 more cycles of chemotherapy.
I can see there was no markers. Huh?
No
But
marker.
all patients there is markers. We always do
There
markers.
was marker?
No, there was no marker in the
In this case, there is no marker.
no marker in the image.
She's doing always markers.
No, but this imaging has no marker.
أنا على image I didn't see any marker.
Yeah.
Okay, but
It would be interesting to know if the markers became outside what we are seeing or not.
It's just that because the initial biopsy was done in another hospital, not in our hospital.
And they didn't.
Plus, they didn't put a marker in. Plus, when we had the tumor discussion, it was felt that keeping in mind the art's nature, she will end up trying to get that.
Which is, I think, what we are trying to find. You know, sometimes when the colleagues in surgery and radiology think she's for mastectomy, they say, why the marker? She will have, you know. So I think that has also, you know, if you do a biopsy, please do a marker.
Yeah, but unless the indication from the beginning is for mastectomy, then that is not necessary.
okay.
So she had two more cycles of chemotherapy.
Okay, so back to pathology, alright.
After total 6 cycles of neoadjuvant, she had a modified hepatic mastectomy with axillary clearance. Final histopath still showed 5 mm residual vesicular carcinoma, positive lymphatic invasion, 3 margins, only 1 lymph node was positive out of 9. Apart from chemotherapy changes, there was total DCIS that strongly hormonal positive and same as that helped with hemorrhages as before.
So we confirmed again that she's luminally by the postoperative histopath. Okay, so
I
what?
see no comment on the skin, nipple, and the...
It was free. It was all free. It was free of invasion, free of meds. We usually
help a lot here.
Yeah, but I'm answering the missing information. Usually they are writing the point of the skin and bone because they knew that we usually want it initially. So the skin was negative and the lesion, so postoperative pathology, there was still residual 5 mm and it was grade 3, not grade 2. Then vascular invasion positive.
So you call it laminal A, and it's grade 3. Still you call it laminal A and grade 3. It doesn't look like. I mean, this is more likely to be a laminal B rather than.
It's laminal B was HER2 negative?
Oh yes. I mean, you don't need to have. One of the criteria to call it luminal B is if you have HER2 positive. But not all luminal B has to be HER2 positive.
30%.
Without, I mean, HER2.
30% of luminal B are HER2.
Yeah, and that's why she's grade 3.
She's grade 3 if she fits luminal B.
Yeah.
Okay.
In order for us to determine this, we need to know the Ki-67. We need to know the
And that is another one, a
which
factor.
we don't have. And you are absolutely right, 30% of luminal B are HER2 positive. So being negative for HER2 doesn't necessarily mean this is not B. 70% of luminal B are HER2 negative.
Okay, so this will bring us for the another question. So if the patient is luminal A and if you assume this patient and you are suggesting the luminal B, is this affecting the strategy, what you are giving both of them?
No, I mean, we're not talking, I mean, I'm just saying the definition.
Yeah, I agree with you.
I mean, we wanted just to make sure that we
The
don't.
response to chemotherapy is more explained by this picture.
Right.
Yeah.
Okay? The initial picture does not fit her chemotherapy response.
Yes.
So now, yes, I think we are talking, you know, sort of, you know, information which match each other. And I'm more relaxed to see.
This is why always the core biopsy or the tissue biopsy sometimes can be representative, and I think it was summarized of Dr. Watson for the tumor heterogeneity as well. So what you will do for this patient, but as postoperative treatment.
Yeah.
So you did Xenopus stadium. She is supposed to be positive initially from the start point. So you give her the convention. Yes,
But
it's a dose
But this is post-neoadjuvant, so you don't know how many of her lymph node area. So you probably have a strong data for, radiating not only the chest wall, but the chest wall as well as lymph node barriers.
But are we not irradiating even one lymph node positive now, or we are not?
If it's very I think the contrast about 1 to 3 positive lymph nodes, I personally don't give radiation routinely unless there is other indication, either external nodal extension or the primary tumor, like it has all the bad features. I try to find an excuse not to radiate the exemplar.
Right, so this patient, she received her post-operative radiotherapy and she started Rosalind and Campaign starting point, and until this moment she is totally free and just under follow-up.
Okay, let me ask everybody, are we sure that this lady, she's only 32,
yes,
she might want to get pregnant again and have a family?
She's receiving Zolodextampen.
No, why do we need to give LHRH? Do we have?
She's high risk. She's high risk lady.
What is the absolute evidence that
she is 32, she's below 35. So this is one of the criteria. The second, okay. Based on the SOFT trial, the subgroup analysis for the patient who's supposed to receive LG or HRH, below 35, high-risk patient, she's locally advanced disease, she has all the criteria, she's grade 3, lymphovascular invasion. What else do you consider high risk?
High risk is not necessarily locally advanced.
It's this tumor size and tumor stage.
3 in 1 does not necessarily, means a high risk.
So how about the grade?
There are so many other factors that you have to factor in.
Okay, so how do you categorize this patient?
For me, this is probably, as Dr. Mithra just said, I will discuss with her the option. She's definitely below the age of 35. If you consider her as high risk, you give her those options. The ovarian suppressions and use of aromatase inhibitors. If you are not considering her a high risk, like just T3 in 1, you probably can go for just tamoxifen or tamoxifen with ovarian suppressions. Depending, for premenopausal. She had. You said that she had four kids, and if she is not worried about her.
No, away from the point of the fertility, you are talking about this patient.
Just whether she is interested in having children, as much as possible. Yeah. You don't want to be, you're going to be stopping earlier because, as well, if you're going to be, saying that she would need 5 years of tamoxifen versus 10 years. If she said that she is interested in having kids after, at the age of 37, and she is adamantly, strong, about that thoughts. That
still, we don't have a consistent data specifically for hormonal positive patients regarding the pregnancy. We have only assumption. All the data we have for the hormonal negative.
We're not talking about protection to preserve fertility and in the adjuvants.
Pregnancy after breast cancer, it's safe, and there is enough data telling us that it is safe for hormonal positive. And even now there is a study, is multi-center study.
I know the one was not
Yes. This one to let them get pregnant after 2 years of tamoxifen. You stop it and you let them. But this is only for nodal negative. No, this is only for nodal negative disease, not for all patients. Hormonal positive and nodal negative. Not
patient choice would probably override
anything.
But in general, if you consider her high risk, I'll probably even advise her for 10 years of tamoxifen, even if you do not suppress her. Okay, because you would probably.
Okay, so tamoxifen we don't have an argument about this patient. Our argument that this patient she needs for Dorsalen or not. So you will give her or not?
I mean,
Because for low risk will not
the
give.
definitions for
high risk you have to give.
based in the soft trial, soft and text, I mean,
She's
analysis.
supposed by the soft
Yeah,
trial.
yeah, I mean, you probably, if you
Yeah.
consider her high risk, then you probably, and you believe the data from that study, then you probably, as Dr. Midrib just said, you will suppress her and give her aromatase because those are, I mean, the one that
Let
have
me put
done.
the argument the other way. Do we have enough evidence to put this in our guideline?
No, it's not yet.
Not yet.
This is a subset analysis from a study which is basically negative.
Yeah, but we still have a big...
That's very important, Dr. Amir.
Yeah, this is
We,
why...
I think it's good to discuss it, but really, when you discuss something, it's what you believe in. You can transmit to patients. We have no evidence to put LHRH plus tamoxifen in a guideline.
Okay.
We say, you know,
Plus aromatase.
we have to really wait for what we can discuss it. If she is not willing, you know, it's not only about pregnancy. We are talking about LHRH for 5 years. You will cripple this lady.
No, it's too much.
You see, it's not an easy decision. I don't want anyone to take it lightly. You know, maybe tamoxifen is the best for her.
I
You know?
agree with Dr. Ahmed.
It is an option, you discuss it with the patient, but not to lean or not to indicate to her that you prefer this option, because it's not yet standard.
I agree with
We
Dr.
have to
Ahmed
think
and
about it.
Dr. Amar Khair that tamoxifen plus LHRH, to be honest, we should not.
You should not
One,
start.
We are strong in our medications.
yeah.
I mean, tamoxifen-
Yeah,
Okay, I know, but you know, I agree with you totally, but for young ladies and for controlling the disease, you always just be in the side that for protection. I agree with you that we have to have a consistent data, and the information is enough to just guide us. In the meantime, you are in the area in between. Which one you have to go? You have to go for the safe area, or you can just, because there is no harm for the patient. I know there's some side effects, but there is no harm.
No, it isn't. Side effect is too much.
So why in the boom trial they started the glycerin for the patient from the day one of the chemotherapy, and they were recommended.
For 6 months.
Yeah, but the main point
For
is,
6 months.
yeah, I know, but if you look at the data and the small group, you will find significance regarding this free and overall survival. And the panel discussion regarding this, they were in favor that for young patients you have to recommend it.
But Dr. Amar, in the book trial, even the patient, she would love to have it because you are telling her that you are protecting her ovary. And this is why she might get pregnant.
So how do you explain the overall survival? So how do you explain the overall survival and this free survival, which is
And to overall survival, it's fine.
it was even specified.
In the soft trial, we started two boys. We didn't know the duration. Some they took it for 3 years, and some for, Man, the survival kid.
So-
It's too early.
So in Bones study, it's different, to be honest. One is the
No, I'm just only putting the fact that
Yeah.
the benefits.
Yeah.
Even what we had was surprising, but this signal, it just give you a hint. And even I was whole road discussion in the hormonal session. She was highlighted that we're still in the beginning and just in full step for specifically for young ladies, because we have to just have a consistent therapy for, specifically for the hormonal therapy for human and patients who are supposed to have hormonal suppression as well. Anyway, thank you very much for your discussion. It was very good.
If this patient had 9 lymph nodes,
I would treat her almost like
yeah, I mean, this is what we could do.